All right. Can you guys hear me okay?
You have to turn your mic on. Oh. There's a little knob thing on the top. Sorry, I already have the
Perfect. Thank you. You guys can go ahead and finish eating, but we'll go ahead and get started in the interest of time. Thank you all so much for being here at our second annual spring meeting for the Nebraska Neuro Society. I know it's a small group, but it is twice the attendance of our first annual spring meeting. So we are definitely heading in the right direction, which is great news. Before I introduce our speaker, I just wanted to say a couple things. First, as always, thank you to Carmen and Tanya and the Nebraska Medical Association for organizing this and making all of this happen. We truly appreciate it, so thank you guys. I also just wanted to mention a couple upcoming events. So the Nebraska Neurologic Society is actually going to sponsor the Eastern Nebraska Stroke Conference, which is going to be held May 25th. It's a Thursday from 6 to 9. It's going to be at Johnny's Italian Steakhouse at Village Point. So this stroke conference, it's been around for several years, but this is the first time it's going to be in person. And it's really a way to collaborate with neurosurgery, neurology, interventional radiology. We'll get together, have dinner and drinks, and discuss some interesting stroke cases. So anyone who takes care of stroke patients or has an interest in vascular neurology is welcome to attend. Stay tuned for emails with registration and follow us on Twitter for some updates. And then finally, we are in the preliminary stages of planning our fall meeting. Based on the interest survey that was sent out in the fall, the topic is going to be neurology research in Nebraska. And so that's a pretty broad topic. And we at least envision that we're going to try and highlight some of the different subspecialties, give some of the updates in that particular area, and then focus on the research opportunities that we have here in Nebraska, where you can refer patients. So if you have a particular interest in one of those subspecialties, or if you do research that you want to highlight on how to refer patients to your practice, please reach out to me or anybody on the board. We would love to have your input as we get things organized for the fall meeting. Otherwise, check the website, follow us on Twitter for updates. But without further delay, it is my pleasure to introduce our speaker this evening, Dr. Kelly Cockett. She is an associate professor of medicine at UNMC. She completed her medical school training and internal medicine residency at the University of Minnesota, and then went to Mayo Clinic for fellowship in both critical care and infectious disease, and is board certified in both. She is the medical director of medical quality for Nebraska Medicine, associate director of infection prevention and hospital epidemiology, and co-director of digital innovation and social media for the Division of Infectious Disease at UNMC. Nationally, she's involved with the ID Society of America and the Society of Critical Care Medicine. She's passionate about faculty and professional development with a particular interest in advancing the careers of women in medicine. She's a requested speaker and very talented writer who extends her expertise through use of social media and her website. Many of you already know her through mutual patients or from her social media and outreach during the pandemic. She's an excellent clinician, and her leadership was really highlighted during the pandemic. She was in a unique position to see things unfold from both a critical care and infectious disease perspective. She's used her platform on social media to be a voice for healthcare professionals and for patients. Because of these efforts, she was recognized as a champion of humanistic care by the Gold Foundation during the COVID pandemic in 2021. We are lucky to have an infectious disease expert here tonight to share her insights on neuro complications of COVID. Please help me welcome Dr. Kelly Cockett.
You really did Google me.
Google.
You warned me he did. That was not all from me. Oh, we gotta go back to the beginning. All right. So I am not a podium stander, so I'm gonna hold two things at once, so don't mind me when my arms are going in both directions. So thank you so much. It really is an honor to be here with you guys. And I think that There has been so much change over the last 3 years. We've been reflecting on a lot of those things tonight already with people that have had the chance to speak with. And hopefully we can go through a little bit more of all of the things that have changed as it pertains to neurology with COVID-19, because from where we started to where we are today, we know a lot more and a lot of things have evolved over time. So I don't have any specific disclosures for this talk outside of the fact that I will wholeheartedly endorse that I am not a neurologist. So when we get into deeper pathophysiologic details, I am not going to pretend I am one, and we're not going to dive to that level in. But what I will tell you is, ironically, if you even look at the most recent publications related to the pathophysiology of COVID-19 and neurologic disorders, almost every article says, we still need to do more research. We don't have as complete of an understanding as we would like. And I think some of those things we'll touch on as we go through the talk tonight as to why that might be and some of the complications and understanding. So objectives, you're not getting to see me tonight. This slide isn't really as critical for you, but I do want to touch on a few things. I am going to start with a little bit of epidemiology, because when you think about what happens over the course of a pandemic, the natural life cycle is usually about 24 months. We are clearly past the natural life cycle of a pandemic. But we have to think about where we've been as we think about where we are and where we go to next. And I think that will become very important as this evolves in our discussion. We'll talk about some of the acute COVID complications, but in full transparency, I really think the biggest and most important piece going forward is the idea of what is long COVID and what does that mean for the field of neurology. And so we will spend a little more time on some of the more recent data that has come out specific to that. So today in history, because again, we have to start with a history lesson of what happens to neurologic disease in COVID-19, but also what did we know before this started, right? COVID-19 with the SARS-CoV-2 virus was not the first coronavirus that we have dealt with in outbreaks or epidemics or pandemics, nor is it the first one that could actually cause neurologic disease. So we did have some basic understanding before we started from its other cousins. So SARS-CoV in the early SARS outbreak in the 2000s, MERS-CoV with your Middle Eastern coronavirus syndromes. Again, similar cousin, both in the beta coronavirus family. And then we have human coronaviruses, which many of these were labeled, if you looked at your respiratory pathogen panels, as your HCoVs, or your HK, Hong Kong CoV, or something else on many of these tests we had early out, where it was like, is it COVID or is it not COVID? Are these all the same or are they not? So these are the three, SARS-CoV, or the original one, right? MERS-CoV and human coronavirus with 229 and 0C43 that really have actually been demonstrated in humans to cause coronavirus-related neurologic disease. When you go to look at these epidemiologically, the neurologic complications actually have been fairly rare, but extraordinarily diverse. There was not a singular entity with any single one of these viruses, which really reflects what we see in the epidemiology of SARS-CoV-2, where we see a huge array of disease and not necessarily a singular phenotype of presentation. So as a reminder, we have our single-stranded RNA SARS-CoV-2, and when we think about how this infected people and how it caused multi-system disease early on, just the reminder that we're talking about the ACE2 receptor, which is really widespread in the body. And you think about some of the multi-organ failure that we saw and impact long-term that we've seen, we really see widespread receptors in the lungs, in the airways, in the vasculature, causing that endothelial risk component in part, in the kidney, in the intestines, and then very widespread in the entire CNS system. This is still considered to be the primary issue for uptake of this virus that causes the direct viral impact. But direct viral impact is not the only part of the story when you think about COVID-19 impact over time. There's a lot of pathophysiologic impact that happens beyond just direct viral infection. And that is what portends to some of the differences in acute COVID and this transition to what I'm going to call for now long COVID. And we'll talk about the various names and definitions of that also. This is the graph most recently from New York Times. This is really important because obviously we have all of the acute COVID patients, right? And we've had varying reports of how many of these patients had true neurologic conditions. One of my favorite things in the literature when you try to look for neurologic condition is what defines a neurologic condition. Was it diagnosed by a neurologist, or was everybody who had any type of altered mental status having a neurologic disorder on presentation? So early on, much of the data was really skewed as to what we actually called those definitions, what phrasing was used, and what people believed to be true. The spikes with acute COVID, obviously huge drivers, especially with the Delta wave that came through in early 2020 with numbers of patients impacted. This second part of this graph becomes really important as we talk about the transition from acute to long COVID, because severity of disease does matter. And when you look at these two different graphs, you have your hospitalized graph, which obviously we see huge swings up and down with the surges that we've seen in the hospitals. But then the ICU wave on the bottom also becomes really, really important as we think about long-term manifestations of COVID-19, because ICU patients are different than other patients with COVID-19. So I want to put this up as a reminder as you think about this over time again, because in a pandemic, time is critical to anything you interpret diagnostically, treatment, and management-wise. So just for fun, so you can see Nebraska. So very similar data through the most recent updates here coming into early 2023. And again, seeing the trend down with the number of cases, test positivity rates, you can see our more recent surge with variants. Hospitalization and ICUs coming down very much like the national curve. Weekly deaths, we've actually seen a little more up and down on here. The way Nebraska has reported COVID data has varied over time. So some of this becomes a little skewed. There was an attempt by the state at one point to only try to report patients who they believed had active COVID-19 infections and disregard someone in the hospital who was admitted for another reason, say a knee replacement, but had a positive COVID test at the same time. So we do have some different variation when you look at data in Nebraska. If you look at pediatric data, it looked for a while like we were the best state in the country. And the only reason that happened was because the state declined to report any pediatric COVID cases. So there are always biases and failures in our data, and Nebraska is prone to that also when it comes to some of this data reporting, which continues actually currently as to what the data will look like going forward over time. So this is what we need to start with after. We talk about acute COVID, and then we talk about this transition to long COVID with neurologic complications. And we should have similar language that we can all kind of convene around to say, this is what we're talking about. It's kind of like the idea of sepsis definitions. You can't say sepsis, severe sepsis, septic shock, and go back and forth without knowing exactly what the definitions of each of those are. This is problematic right now because there is not a national or international standard that has truly been set for the definition of when acute COVID ends and when this idea of a long hauler or long COVID starts. There is now a national task force being developed to provide the actual definitions of this and the syndromes and provide greater recommendations. But that group, to my knowledge, doesn't even have the entire group yet selected because the call for new faculty to join in that just happened in the last probably 6 weeks. When you look at the data, acute COVID is anywhere from when you start day 0 to up to maybe about 4 weeks. I would say most groups have landed on maybe up to 4 weeks. Long COVID, the early end of it is 4 weeks or more. But some groups use 12 weeks. Some groups use 8 weeks. Some use 6. Some go out as far as 20 weeks before they actually call it long COVID, long hauler, post-acute sequelae. So we have ambiguous COVID, which is anywhere in between here where we don't really know because we actually don't have a good clinical definition to make this diagnosis. which makes it extremely complicated when we talk about where on the spectrum these different disease processes lie, and where our patients are where we would expect to see more rapid recovery, and what the pathophysiologic impact is at different points in time, causing different syndromes and symptoms. But we'll start with acute COVID. So who gets neurologic complications? The high end, about 75% of any patient with acute COVID is going to complain of something that has been deemed neurologic complication. Again, I will let you decide how you feel about the definitions of neurologic as we get a little farther into this. What we do know is that it doesn't matter where in the spectrum of infection you are. Ambulatory patients absolutely have had neurologic complications. But the more severe the disease, the higher the risk and the higher the severity of those neurologic complications have been. So as you move to inpatient, even if you're not hypoxic, risk rises. You land in the ICU and you have hypoxia, risk continues to significantly rise on who develops true neurologic complications and how severe they are, and then also how long lasting those repercussions are going to be. So the most common neurologic complaints, if you go back as far as 2020 to the original data, headache. Now, I'm an ID doctor. I'm also a critical care doctor, but I'll put my ID hat on, right? If someone tells me I have influenza and a headache, I am not going to be like, neurologic complication. I'm going to tie that with their fever and just say that's part of the acute infection, but I wouldn't put it necessarily myself in this category. No, maybe I'm wrong and maybe it should be there. But if every COVID patient is diagnosed with a neurologic condition based on their acute headache, you guys have a whole heck of a lot of people with headaches to deal with. And I'm sure that is your favorite population to always have, right? And then the next two common neurologic complications over time throughout the literature are either a loss or change in taste or smell. Again, nothing new there, but how far down the true neurologic complication do we call this? This begins really interesting, and yes, absolutely based in neurology and pathophysiology of the CNS system and our peripheral nerves. But are these the same complications when you think about as a group, as a Nebraska Neurology Society? Are these the conditions that you care the most about? Because this is what the data is reporting when you dive in and look at what's diagnosed as a neurologic condition. As you get a little farther into the pandemic, we get a little better. So this is actually one of the best tables. It doesn't cover all groups because for a long time you couldn't get good data on ambulatory patients because they weren't tested, they weren't enrolled in studies, they weren't accessing care as often because there was no care available to them, right? If you were sick, you got in, people paid attention to you. Critically ill patients, we all paid attention to because they were everywhere and we were overflowing with them. A lot of these conditions were consistent with what was reported in hypoxic, non-critically ill patients. The ambulatory patients really held onto that headache, change in taste and smell, fatigue. Now, I don't know that I would put fatigue as a neurologic diagnosis either, because there are so many manifestations, but it is dropped in that bucket in many studies. So from the ICU standpoint, when you look at encephalopathy, stroke, and specifically here they were primarily talking about ischemic stroke, encephalitis, Guillain-Barré. Encephalopathy by itself. If you are critically ill and you have sepsis and you are on sedation and you are paralyzed on steroids and everything else, it is impossible to tell the difference between acute COVID-19 and sepsis and critical illness causing encephalopathy. That is a box that is extremely hard to tease out the difference of, and actually most of the neurologic literature does not talk about the difficulty in calling that out. It's really hard to tease out. If you look at the data on where was the virus, it wasn't in the CSF. Very rarely was any virus detected in any CSF. Many of these didn't even have a pleocytosis when they were tapped, looking for it. Now you can find some cases where you start to see more of like an ADEM presentation where you might see it in the brain parenchyma. And there are some rare cases of that, and that is true with all of the coronaviruses, and actually true of most viruses that can cause critical illness, such as influenza. Stroke. Yes, it causes an inflammatory storm. There's a cytokine surge. There are also pre-existing conditions that were actively issues when you look at risk factors for COVID-19. Early on, the incidence of stroke and the percentage of patients being diagnosed with stroke was as high as 35% in 2020. When you look at the data most recently, the strokes attributed to COVID-19 are as low as 4 to 5%. Huge transition over time. Is it because COVID has changed that much? In part, yes, probably because of the level of illness, right? And the amount of inflammatory cascades, cytokine storms, endothelial injury, right? And eventual thrombosis from that with the hypercoagulable state triggered by that. But guess what? That happens in sepsis too. So it gets really interesting when you try to tease these out and say what is caused by what, and what do we do about it differently, if anything. I'll talk a little bit more about Guillain-Barré, so I'm not going to spend too much time here, but I do want to use this just as a really key piece of understanding that when we've watched this over time, there are absolute neurologic complications, but understanding how much the virus drives versus how much the level of immune response and inflammatory response drives versus how much pre-existing conditions drove these issues is really, really difficult to tease out, and I do not envy you that job when you have to try to explain that to patients. Now, this is my non-neurology version where I'm not going to dive all the way into this, but I really love this particular image. It's from a publication from 2022, and what I love about this is a few things. One is it actually shows you from an image standpoint the differences between acute COVID and long COVID. The issues with actual viral receptor uptake by the ACE2s, the disruption of tight junctions and blood-brain barrier, and the ultimate impact both potentially directly to the CNS, but also with the cytokines coming up, activating platelets, causing further hypercoagulability, vascular injury. Direct and indirect impact of COVID-19 infection causing substantial risk to CNS and brain. The thing that's interesting are the arrows on the bottom, right, for long COVID. We're talking about more chronic neuroinflammation. We still don't really understand if there are true viral reservoirs like HIV might have in the CNS. But we do know that there's some chronic inflammation and there's actual changes in metabolism with hypometabolism in several areas of the brain and structural changes that do arise from anybody on the spectrum of COVID that you can see on different imaging studies. But you're still driving this low-level cytokine shift with that. It's an inability to turn off the dysregulated immune response that happens that is triggered by an infection. There's nothing on the market that we have that can turn that around. We know that because if we could, we would have fixed sepsis a long time ago. We have tried a lot of things to fix dysregulated host response to infection, and so far we've been unable to do so. It makes it extremely difficult and frustrating because it's a diverse spectrum of disease, it's a diverse pathophysiology that we still don't think we fully understand in full, and it transitions to this chronic inflammation. Now, is that true in all patients or is it in a subset? Studies are still coming out on long COVID because we're not that far into a pandemic in which we were actually capturing patients with long COVID effectively enough to say all of these details of the long term. So we still have a little bit of a black box to learn from. Now, I know many of you can speak to this pathophysiology better than me. This is my kind of image here. So this is from the pediatric literature, but I love it because it does come back to the simplicity. Direct viral invasion, immune dysregulation and prothrombotic state, multi-system failure and dysfunction. COVID does all of these. It does all of them in different spectrums in each patient. It is not predictable, and the phenotypes of how this manifests patient to patient are just now starting to come out in the literature. And even with the attempts of describing phenotypes to understand, it's not clean. There's not a clear definition yet to say someone is in this bucket versus this bucket versus this bucket so that we can predict their outcomes and intervene with appropriate treatments. I also think when you look at neurologic manifestations, now again, this is very specific to pediatric literature, but I showed you that critical illness list also, and if you look at it, turns out kids, other than seizures, pretty much show up with many of the same presentations, but they do so at a lower prevalence. So pathophysiology at this point in children appears to be the same as adults, which makes sense. Even though kids are not little adults, I'm not a pediatrician, I do appreciate that. But there are some slight variations. It's approximately 1 in 3 adults will have some clinical, based on a neurologist evaluation in the literature, diagnosis related to a neurologic dysfunction in COVID. Kids are about 1 in 5. Every percentage in every study that I could find shows a lower prevalence of any neurologic manifestation in children compared to adults, and the reason for that is extremely poorly understood. We do not understand why children do better than adults, but they do, unless it's comorbidities and other factors that are still not fully delineated out in the comparisons. And like all things, pediatric literature lags behind adult literature. So we have a lot more to learn as it relates to that. Now, Guillain-Barré, when this started, when the pandemic started and we started to see the first cases of this, there was a lot of concern that in the spectrum of Guillain-Barré, we were seeing more than we thought. That this was going to be a higher prevalence, higher incidence, worse than any other infection we've seen triggering these before. So when you look at the literature overall, 2/3 of all GBS cases have some kind of preceding infection. Right? We think about Campylobacter from board exams all the time, but viral infections, and that cause respiratory infection versus GI infection are your most common. When you look at viral triggers, ADIP is the most common manifestation that we see. That is true in COVID-19. Interestingly, a couple studies have compared this to influenza over time. Is it really better? Is it worse? Is it the same? These results are varied. Some studies actually are saying that there is less Guillain-Barré in COVID than there was in influenza epidemics and pandemics. Now, influenza is tricky because every season we have a different virus, we have different variants rising, just like we have seen with COVID. So it's not always apples to apples. A few studies have said that perhaps indeed there was more Guillain-Barré than in influenza outbreaks, but it's not by a lot. So it's really on the spectrum of what we'd expect from a bad viral epidemic pandemic. It is less common than Zika virus. That was consistent. So there are other viruses that are indeed worse. So just as a point of optimism, it's not all doom and gloom with COVID. There's a few things out there that are still worse. Treatment isn't any different, right? There's no other treatment option that we've had to say in these viral infections, specifically to COVID-19, that we can treat the neurologic manifestations in a different way. We'll touch on what happens when you treat COVID-19 in a couple slides. And outcomes, at least for those reported, not huge studies that I can find, but of the studies I can, really the outcomes appear fairly similar to what you'd expect from any other infectious trigger of Guillain-Barré. Cerebrovascular disease. I really wanted to specifically talk about ischemic stroke, but that's not necessarily fair because there's many manifestations, including hemorrhagic stroke, right? Venous thrombosis. Higher risk than influenza. So if you go back in time and you compare these two, which have now been done, this absolutely is worse for your risk of stroke, particularly driving with the ischemic stroke component. But the epidemiology has changed profoundly over 3 years on what is the incidence, what is the prevalence, and how big is this impact really for us long term. And what we've seen is that early on, we saw way more cases of acute stroke. Now, is that because the virus was different when it first originated? Is it because we've had more treatments, more vaccination, more immunity forming, causing less of an immune reaction? Or is there something else at play, which is really selection bias for those with pre-existing conditions that were high risk for stroke to start with, and they were high risk for COVID, and they got knocked out early with their strokes? There's a combination of factors there that we can't delineate well. But we do know that pre-existing comorbidities absolutely matter. But how they play with that vascular inflammation and endothelial injury is not well understood. That cannot be elucidated by the pathophysiology to date. So if someone has had a prior stroke, we know their risk of a stroke in COVID is higher. If they have hypertension, their risk is clearly much higher. But then we also had clear young patients who came in with severe COVID and had significant thrombotic strokes and ischemic strokes. Was it because they had comorbidities that were not previously diagnosed and only got unmasked in COVID? Or was it the virus itself? Again, really difficult, but clearly there's some duality here with both the inflammatory triggers and those hypercoagulable states and the severity of disease. Again, huge bias on what was reported early in the pandemic because only the sickest patients were reported. They were hypoxic, they were hypotensive. Any decrease in blood pressure and oxygenation to the brain obviously is going to worsen this picture. So again, where does this lie going forward? As we continue to see COVID in our communities, do we expect to see future rises of more ischemic stroke? We don't know. But the data would suggest probably not, unless we have a massive new variant rise, because over time, the incidence, prevalence, and severity is continuing to drop over the last 3 years. What we do know is how you treat COVID-19 matters for neurologic manifestations, and it has taken us a long time to get this data. This was published in 2023, and it is the first and only study I can find of a significant number of people that can actually tell you what the hazard ratio is of neurologic complications in severe COVID if you're given treatment with dexamethasone and remdesivir, one, both, or either. In every sensitivity analysis for what it is worth, this graph looked almost identical. So they did not see changes when they attempted for the smaller cohort of non-hypoxic patients. They did not see changes before and after more formal approval. The study was done in the UK, so their approval for the drugs was a little different than it is here. But what was very clear was that if you treat COVID-19 and ideally combine treatment, these bottom two dots, the earlier you do it, the less likely you will see neurologic outcomes in acute COVID. And doing it at any time is better than not at all. So the best treatment that we have specific for this is to actually treat COVID-19. This matters because one of the issues that we see now is when patients get admitted to the hospital, we know there's a clear indication for remdesivir in high-risk patients, even if they're not hypoxic. It is actually rarely given. So if your patient is diagnosed with COVID-19 and they have underlying comorbidities, they're immunocompromised, they've had a prior stroke, you can give remdesivir inpatient, outpatient. I do not have data on Paxlovid. Again, it's taken till now to get this data. But it does appear that anything that treats this, likely because of the decrease in overall viral load in those patients, will prevent development of acute neurologic complications. I want to touch on this briefly, and we could talk about this forever by its own topic, time. We know that the vaccines have been reported to have neurologic complications with significant depth and breadth of the type of complications through the VAERS system and also internationally. When you look at the data to date for the mRNA vaccines and the millions of doses given, the rate of neurologic complication is exceedingly rare, exceedingly low, and very similar to other vaccines over time once you start to get the broader population data. The one vaccine type that stands out is viral vector, or the adenovirus versions of vaccines. So that is not something that we are using here in the US routinely anymore, But when you look at data related to vaccines, you really need to understand, especially on the international spectrum, the type of vaccine being used. Viral vector-based vaccines cause a much more profound immune response, but then they carry with them molecular mimicry and autoimmune reactions that are causing more neurologic damage at higher levels. So vaccine does matter. So if your patient comes in from an international location, which we have seen happen, and has more manifestations, it may be related to this. But again, at least the larger populations of mRNA, this is much, much lower than was previously thought to be true. From what I heard, I didn't hear that there were any pediatric neurologists in the crowd tonight. Is that true or is that not true? Is there somebody here who is? Okay, I'll keep it short and sweet. This is my daughter. This is her EEG after she had myoclonic seizures for 35 minutes when she developed Delta COVID infection. You can see how happy she is. This is not her first EEG, by the way, after all of this. Loves it, right? Everybody's favorite. Pediatrics is just different, both because of the risk of febrile seizures, but their presentations are absolutely different. And it does impact the way we think about them, especially in understanding the differences with MIS-C or that multisystem inflammatory syndrome in children, which is really where you see the higher risk of neurologic complications. In kids, overall, very similar to what I showed you before, outside of seizures and febrile seizures, very similar to adult manifestations that you're gonna see, especially both in acute and post-COVID. There is just now starting to get more early data. That's really the volume of patients we need to explain post-COVID syndromes in children. I worry a lot about what happens with the kids and whether we recognize, coming out of the pandemic with all of the social implications, the school changes, some of the long-term effects that some of these kids might have, especially in the executive brain functions, and whether we're going to actually intervene in time. I worry about whether my daughter is going to have long-term impact because she clearly had severe manifestations when she was presenting with her seizures and very prolonged seizures. But for those of you who are seeing these patients as they're coming up older, maybe you have some of those transitions of teenage years. Again, overall, far less likely, but if they were diagnosed with a MIS-C syndrome, you go up to about 46% of those kids are going to have some kind of longer-term neurologic deficit, whether or not we fully recognize it and whether it's more executive brain function versus something on exam that's going to be more readily obvious. And with that, I'm going to switch to this last part here for you, which is don't forget the tail of the beast. So in a pandemic, we remember the front end, the first surges, the horrors of the overwhelm. People do tend to forget the tail of the beast that comes back to bite you or sting you later, because that is the impact on the healthcare systems from the long-term side effects. We haven't even seen the full impact of that yet when I show you those graphs of disease, because we're still seeing active COVID infections. And we know that if we're talking out as far as at least a year, we are just now coming into where we might be seeing kind of some of the maximum Delta impact. Has nothing to do with maximum Omicron yet, let alone the other variants. So it becomes really important to think about. And it becomes really important because, again, we still have terrible diagnoses. We don't know what the right timeline is. All the definitions are different. And trying to understand who is at risk based on those timeline differences is really hard. 4 weeks is not the same as 12 weeks later, right? And what is the end of acute and what is the beginning of long COVID? So this is an article that was just published on March 23rd from JAMA. And the red is the only data point in here that is not from the actual analysis there. But in an attempt to try to understand who is the highest risk categories for having some type of long COVID syndrome that extends beyond the 8 to 12 week timeline. Women, the older you are, the higher your BMI, if you smoked, if you had any of those prior pre-existing conditions, or if you've been hospitalized. Now, if we take higher BMI, age, and pre-existing conditions, you have the majority of Americans. Terrifying, but true from an adult practice standpoint. There's also issues with this data on survivors, right? Because we tend to remember the survivors who were documented for having an infection, and there's a whole lot of survivors that never got tested, never could get tested, refuse to get tested today. So we think it's about up to 1 in 3 now. It used to be 1 in 10. The data still is very biased. With the advent and easy access of home health tests, most people do not report them to the counties or states. How many of you knew that if you have a home test, you can go to Douglas County and report your positive test to be counted in the statistics? 3. So every 4. So when we look at those graphs of the state of Nebraska, or you look at the Douglas County data or DHHS data, every home test is not being recorded, which means we are grossly underestimating the burden of COVID in our communities right now, because that is what people are relying on, and nobody knows to go and report it, and very few do. This is a great piece from these articles also that I was reviewing. This is the problem with long COVID. This is the problem we'll face in neurology with it, and we'll face as a healthcare system overall. We have way too many definitions. How do you diagnose this? How do you explain this to a patient? How do you interpret the data study to study when it's not generalizable because of the time differences, the population differences? Anything from 100 days to 12 to 24 weeks to greater than 1 month. There's no other diagnosis that we have medically where we're like, anytime between now and a year from now, if you have some kind of symptom, including fatigue or headache, we might attribute it to your viral infection. Right? Really difficult, I think, especially from a neurology standpoint, because so many of these symptoms in the bucket of neurologic manifestations of COVID are very vague and may or may not have true causal pathways purely from a neurologic disease process. So WashU had a great graph on this. This is one of the early ones. If you look at the Lancet, Nature, or any of the other new ones, you'll see very similar scenarios. What can long COVID do? Anything. It can affect any of the organ systems. It can cause all kinds of different manifestations. They do not all happen together. You may have one, you may have several, making it one of the most ambiguous diagnoses also to make. It is truly a diagnosis of exclusion to call something a long COVID, long hauler, post-acute sequelae, whichever definition you'd like. Now, when you look at the neurologic manifestations again, we come back to this. What buckets do we have? So, CNS versus peripheral. How many of these, when you look at this list, would you automatically assume are truly neurologic driven? Or would you be worried that there's a whole lot of other medical conditions that may be driving these? Extremely hard, right? These are very broad. They're not as discrete as we'd like them to be. And they can have a multitude of causes, including psychiatric disorders and other organic organ dysfunctions in other parts of the body that may trigger these. Again, really hard neurologically to have someone come into you and say, I have long COVID. And for you to know what to do with that right out of the gate. Even, is that real? What definition are you using? And what symptoms and what evaluation have you had? So from that perspective, you probably do need to be farther down that road of evaluation and shouldn't be the first evaluator because of how many other organ systems can be involved and be causing many of these symptoms. So this is another study from late 2022. I will strongly suggest, if you want to know what all of these categories are, they have this separate table with all of them. There is no way to put it in a slide cleanly for you for what fills into each of these categories, but it's extremely broad. And this is the 12-month burdens of post-acute composite neurologic outcomes. Any neurologic outcome on the bottom. Really significant increased risk, but in general, we're looking at hazard ratios ranging from 1 to 2. Most of them are around 1.5. To be honest, when you look at all the other pathophysiology, I really thought that would be a higher hazard ratio. Excess burden, huge excess burden coming in related to these different complaints. This comes back to those graphs at the very beginning epidemiologically. Anybody can have disease processes, but the severity of illness matters. Green is non-hospitalized, red is hospitalized, and purple is ICU patients. The problem with many of these diagnoses, especially as you get to the ICU part, is that post-intensive care syndrome can look very, very similar to what post-COVID syndrome is. And if you pull that out even farther to any type of post-sepsis syndrome, many of these can have significant overlaps. So again, really hard to tease out what is truly viral versus what is being indirect because of your prolonged illness and the treatments you received, including steroids, ventilation, even some of the medications like remdesivir. So this becomes a huge uncertainty of clinical diagnosis. What is it really that's driving this? And are we really sure that as much post-acute COVID as we're calling is not the under-recognition of symptoms that are more aligned with PICS, especially when we saw most of this disease burden early on in the pandemics? This is a big question I think that we need to understand more. And I think it's important as we think about going forward into the future, because we have avian influenza, guys, on the arena right now, where it is spreading rapidly to more and more mammals. Not to scare you, but the reality is legitimate concern, followed by the biocontainment unit. Every week we talk about it. Marburg is back. Could cause a global pandemic if it actually spreads effectively. All of these viruses have similar capacity to cause similar syndromes if you go back historically. But understanding what is what in the pathophysiology, I think, becomes important when we understand who is going to be the highest risk going forward. So this is one of the algorithms proposed for long COVID, specifically when you have neurologic symptoms. Now, I think this is fantastic at demonstrating that you have to rule out everything else first. Make sure you don't have organic disease processes that are not treated, right? Make sure that you don't have post-intensive care unit syndrome. Make sure it's not related to other psychiatric conditions that you still have missed that weren't in the premorbid conditions. And then start looking neurologically at whether or not there might be something that's purely related to COVID. And then at the very end, maybe you get there. The downside of this is when you look at the treatment categories. If you can't diagnose a non-neurologic problem that you can treat in your patient, you have neurorehabilitation, right? That is the treatment. So making sure that we are really doing a great job of evaluating these patients and doing it in a multidisciplinary way becomes incredibly important to rule out all the other potential causes before we even come down to this question of should it be diagnosed as a true neurologic complication that is going to be a long COVID diagnosis. This is very similar to how setups in PICS clinics have worked historically. You know, in Nebraska, we have failed to have adequate PICS clinics for years. CHI had one for a period of time that did not have a high referral base. Nebraska Medicine has not had one. You now have some post-COVID clinics that hopefully will transition to a little more PICS expertise in which this multidisciplinary and rehabilitation programming can be done effectively for patients, but we are a severely under-resourced state for treating patients, despite the fact that we have a very high burden of COVID in our state and a high burden of patients who are not vaccinated and who had severe disease and survived. So time for change. What does it mean today when we look at the pandemic? Washington Post just published this week. They actually used Epic data in conjunction with Epic to publish this. And I think this still highlights many things, and at the end, something really important. So this is new symptoms 6 months before infection is kind of your baseline, and the rate after is new symptoms 1 to 6 months after infection. So giving us that long array of what is long COVID, right? So ICU, still worse than hospitalized, still worse than not admitted, but small percentage still having symptoms. We know that. What about those pre-existing conditions? So we talked about no comorbidity versus some comorbidity. So if you were healthy when you got COVID and legitimately healthy, like you'd been to a doctor, had an annual exam at some point and knew you didn't have hypertension or anything else, pretty low likelihood that you really have a long COVID syndrome, although possible. You had any of these, including obesity, which again, in this country, in this state, is a significant issue, your percentages start to go up at a level that's tripled. And this does not account for when you add, if you have multiple of these, which many of our patients do, right? We really can't see the full impact in an additive way to understand, is it really like a synergistic add where it really exacerbates and worsens? But I think this is my favorite slide that they came up with. This is the one that really matters to us today. Where are we? How bad is it? And is it going to get better? Over time, we have seen slow and steady decreases in the amount of symptoms after a COVID infection with the variants. Now, this is confounded again by treatment, vaccination, and changes in the pathophysiology of each of these virus variants. But it is decreasing, and again, unless more variants arise that are really substantially different, which right now there is not one on the horizon we're all worried about secretly in the ID world. Hopefully this will continue to come down, and we've already seen our major Omicron surges with the variants that are out there to date in this country, including our maximum surge of our new variants here. So what we have now, hopefully we actually have our maximum number of the most severe long COVID patients in the state already here and already symptomatic. Whether they've sought care is a different issue. Vaccine really matters. It's a political issue in many ways now. I'm not going to debate that. This is the original 2-series only vaccine, not including boosters or any of the other subsequent additional add-ons to the original series. Any vaccine versus no vaccine decreases the risk of long COVID symptoms. Again, activating the immune response, dampening the inflammatory response. It does matter. We anticipate it still matters when more studies come out. But for the patients who are unvaccinated with severe COVID, risk really substantially higher that they are going to have true long-term manifestations that can be lifelong, potentially. So when I say lifelong, and we think about that as an implication to healthcare as a whole, when you think about post-intensive care unit syndrome, there's data that patients are still suffering at least 5 years out when they've done longitudinal studies that far out. You can expect this to be easily into the months to years realm for some of these patients. And they may never functionally get back to full capacity, especially if they were in the ICU and had critical illness myopathy, right? Polyneuropathy that arose with that. But we have a lot of implications when we think about the healthcare system going forward, especially when we think about the attrition of healthcare workers in general in the state, but also in the country. Access to care was an issue pre-COVID. It was a clear issue with healthcare inequities mid-COVID, and it's going to continue to be an issue post-COVID. Getting in to the right people at the right time in a way that you can afford is a major issue to getting people back to their lives, to being productive members of society and avoiding longer-term impact. Money. There's a lot of cost that we're still going to have in healthcare because of COVID that's going to be that tail of the beast for a long time. It's all of the sick patients that we have. It's our staff in our healthcare systems that have long COVID symptoms. It's the loss of money that people are trying to catch up to in the healthcare systems for when the surges happened and they shut down surgeries and other pieces. The ramifications of cost of care and the ability to continue to provide high-level care to patients who need it and make it financially feasible is a problem. It's very, very difficult to actually do this right now, and with the COVID emergency ending in May, this will become increasingly more difficult. And then M&Ms, this is your morbidity and mortality. They never end. There's always a different variation of them, but the implications we don't really understand in full yet. We don't know how long this is really going to last. Is it going to be like PICS where it's years of symptomatology? Are we going to find out that we do in fact have patients who have long-term live viral reservoirs akin to something like HIV or other things that lie dormant like VZV, HSV? We have not seen that with the other coronaviruses, but this does behave differently, and that is a point that we still do not fully understand. But we're going to be talking about morbidity and mortality related to COVID for a very long time, because COVID, unfortunately, is still here and is not going away in the acute or in the long-term sense. So the ID doc and the infection control doc in me just has to end this way. Although the community and the state, we are seeing the masking requirements release. We are seeing testing requirements release. The reality is we are not done yet. We are still at high levels of transmission. The wastewater data is very high. There is still active COVID, which means there are still patients who are going to have long COVID, starting from their infection that they have today. So the story is absolutely not over, and it's going to be difficult. And I think from a neurology standpoint, the one thing that we see is that we're not done yet with COVID. We're not done yet understanding long COVID. We're not done yet figuring out when and how and who should actually see a neurologist if they have long COVID symptoms, and for which symptoms. How do we help not overwhelm neurology clinics with patients that they may or may not be able to help, so that the patients who do need a neurologist can be seen? You're a hot commodity. You're limited in number. You cannot see every patient who's had COVID who might have long COVID in the state of Nebraska, nor can your profession do it in the country. So how we build better multidisciplinary systems in order to address, test, and work through this, I think is going to be a long-term challenge that requires more collaboration than we have historically had in our subspecialty silos. So with that, there's a whole list of references here that are some of the key ones and some of the more recent ones I referred to. So if anybody wants them, I'm happy to share this out. You can take a screenshot. Otherwise, with that, I will end. Thank you so much. I'm happy to attempt to answer questions if anybody has them. If not, that's okay too. Yeah.
That was a really great question.
Thanks.
This is why you're winning awards. Even in neurology. But so long COVID is a problem and it's with us. And you mentioned a hypothesis of viral reservoirs. So is it worth a shot at antivirals in patients who are complaining months and months after original diagnosis? It's kind of like, what have you got to lose?
Yeah, so it's a great question. So at this point, what I can tell you is it is a consistent hypothesis in the literature, zero data to actually support it. And because of some of the risks with it, remdesivir and Paxlovid have not been, to my knowledge, trialed effectively in any large-scale study for long COVID. Could it be done? Should it be done? It probably should be done at some point. I think there have been some smaller studies that are way too small a sample size to give us a really good answer to that, partially because of the definition of when is it long COVID. And have you ruled out other medical conditions effectively before you get to that? I think you have to get to the diagnosis of exclusion and then say, I've got nothing else to lose. And that's a hard place to get to, and many of these patients do have some other concomitant diagnoses, especially in the mental health realm. There is one study that's reasonably sized that would say even if your patient screens negative for depression, PTSD, or anxiety, the use of antidepressants in long COVID may actually have some functional benefit. Mental health studies are so biased with how people self-report symptoms, it's really hard to understand. But I think if we could get to the point with a large enough cohort where we could rule out the other pieces and we're still dealing with symptoms for a period of time, could that be a possible study? Absolutely. But right now it is not routine or recommended in any guidance or anecdotally locally by any of the ID physicians that I'm aware of.
Thank you. I mean, so we run into patients in neurology clinic from time to time with unexplained neurological complaints. We scratch our heads. You do what you can do, right?
Right.
So there are things like cognitive behavioral therapy. There are things like exercise. I mean, when you think about your approach to things like seronegative Lyme disease, what do you do with those people?
Right.
Shouldn't it be the
Yeah, so in ID clinic, we will not give anyone with Lyme disease antibiotics if they come in if they've already been treated once appropriately for the longer course of therapy. So chronic Lyme does not get a dime of ceftriaxone or doxycycline in our clinics because we know that it's immune driven. Now, the one thing that is coming out more and more data driven is that we have not found SARS-CoV-2 in viral replication in CSF, even in acute neurologic disease, which speaks against to that potential at some point. And there is clear data about the immune and autoimmune responses. And you've seen some of the anti-NMDA and other triggers that happen in that scenario. And so I think, the postulation of is there a reservoir that causes some of these long symptoms is a continued postulation in theory, but there's really no evidence behind it to say this is going to make them better. And I think until we have that, I do not think the ID community, at least, will prescribe antivirals to anybody in that setting. It's kind of like chronic EBV. We don't treat that either, but you do see it come up, CMV in an ICU, all of these other viral things that we don't treat. But it is a fair question. I think there's more data to come on it if it can be proven. Yeah.
It was a great lecture. Thank you. I do not have the data to back this up, but I just want to run it by you. It has been my observation in clinic that some of my long COVID patients over the last 6 to 12 months are getting better. And it's even more so than I had expected compared to other kind of maybe comparative post-viral syndromes that we've seen in the past that might cause chronic fatigue syndrome in the past. And I had the idea a couple of years ago, are these patients going to all have chronic fatigue? So,
we just talked about that earlier too.
and I thought or just assumed that may be the case, and many of my patients are proving me wrong. I don't know if we have any longitudinal data on the prognosis on this, but it almost seems different compared to some other infectious diseases.
Yeah, so there's not, as far as I could find to date, the longest large cohort is about 12 months. And there are percentages of patients who are slowly continuing to improve and improving past kind of, some of them were like 12.6 up to 14 months on a few long ends of that monitoring. The closest corollary, I think, actually, because again, severity of disease was such a huge driver of this, is post-ICU syndrome or post-intensive care syndrome, where you could see at least a year before you actually saw substantial improvement, but some patients did improve faster than that. And again, this is where some of the phenotypes of why are some people responding differently than others and what are the innate differences of those people? Was it actually viral driven? Was it not? Was it related to something else that happened when they were ill? Are pieces that we don't understand well.
Was it the wrong diagnosis in the first place?
Right, exactly. There's so many pieces of it. Like, was it really ever a long COVID syndrome? If we say you can go out as far as 100 days, so does that mean like if I had COVID 100 days ago and I didn't complain about neurologic stuff, but now I have fatigue 100 days later, do I blame that on COVID? Like, that's really hard to say, is that the correct diagnosis at this point? So I think there's a lot of ambiguity because of the definitions, the times, and I think as we see more patients over time who've been evaluated effectively, we'll have better answers to that. But it is a huge question of what is the rate of improvement, who's improving, and is there something they're doing?
All right, I have to make a second comment. Thank you. This one is unrelated. Looking at the neurological symptoms on your presentation that tend to be seen post-COVID, the two that I've seen, I think the most severely are not quite represented on there, but one is severe lower extremity numbness, burning, and pain with normal evaluations, just lower extremity pain, almost kind of like small fiber neuropathy. They're worried about Guillain-Barré syndrome, but all the testing is negative. And the second is POTS. Is hypotension, tachycardia, exertional fatigue. I have seen a lot, and that's been some of my most disabling post-COVID.
Yeah, so POTS does fall into this, and part of it was up there. There's also clear heart rate variation or heart rate variability, HVR changes that are happening that are not actually meeting criteria for POTS if you truly do POTS testing, but act physiologically just like POTS. And that particular cohort is really interesting in the difference of, is it POTS, is it not POTS, and what do you do with it? But it's profoundly disabling. When you look at the data, at least for some of these that are in a little more of the heart rate variability to maybe POTS, where they're right on the edge of diagnosis, over time they do seem to improve. Heart rate variation improves over months, as does exertional control, and they tend to get better. The true POTS met full diagnosis, I have not seen data that says there are great outcomes on recovery of those. But there's a lot of people that act like POTS that actually don't meet your diagnostic criteria. Yeah, borderline, or this other condition that really nobody ever thought about with this massive heart rate variation disease and inappropriate tachycardia syndromes, inappropriate bradycardia syndromes. As far as the neuropathy, if I go back to, let's see if I can go back in time to this one table. So this particular study actually does talk a little bit more about all of the variations of peripheral nerves in there, but it doesn't talk about outcomes at all. And so there are some small fiber related syndromes, something like what you're talking about. There were smaller numbers in the study and they did not do a good job providing any type of description of exactly what it was. But they do have them in this study outlined out in full. So it's probably the best about the occurrence of it and the burden of it, but nothing about what to do about it.
It's symptomatic treatment.
Right, and that's most of what everything is at this point, is symptomatic treatment, rehabilitation, and time, which is very unsatisfying for patients, as we all know.
I remember I used to send patients to COVID clinic.
Yes.
Are we still there?
So as far as I know, they are still going through the post-COVID clinic. So there's two primary ones in, I guess I can't speak to CHI. If someone's from CHI can tell me if there's anything functioning there now or not. There's two that are affiliated kind of with Nebraska Medicine. Nebraska Medicine proper will do an intake for post-COVID clinic. If you call the call center and ask for the evaluation, it'll be done by a primary internal medicine physician. They will go through mental health screening, they will go through symptom screening, and then they will refer them for all of the multi-organ disease processes and try to rule out other organic pieces, and then kind of try to filter them to the appropriate treatment specialty as able. The other one is for more severe rehabilitation needs, which is really coming through Madonna with PM&R. So in that clinic, they do have more capacity there to take the severe ICU patients with myopathy, polyneuropathy, physical deficits that are more substantial. Yeah. Oh.
Good.
So my question is related Matt's question as well. So, you start them with steroids when they have respiratory starts, right? So when you see a patient with cold pulse, asymptomatic of respiratory, but have, say, a stroke or something acutely from neurosurgery, is it valid to start with that severe or just hold on that?
So I've absolutely started people with, if I cannot explain their end organ manifestations with some other clear pathophysiologic thing, or I think it might be related to COVID at some point, I have treated people with diarrheal illnesses, CNS manifestations, whether it's stroke or some other seizure presentation, they have acute COVID. One of the things testing-wise that Nebraska Medicine can do, I know not everybody can do that, is that it would be a scenario where we can call and look at the CT values and try to tell you, is this acute COVID or is this resolving COVID? How much of a player do we think this is in this scenario? In those settings, what we usually will do is start remdesivir and then repeat testing if we need to get that answer, and then stop it if we find out that it really is resolving COVID. If you're relying on home tests or antigen tests, you believe, right? That's only going to happen in the first 7 days of a COVID-19 infection. You're not going to carry that out into a viral shedding phase. The PCRs are where it is a little trickier to interpret that, and getting a little more data on how much virus is there can help you make that decision with more confidence. But absolutely, without hypoxia, I treat people. And a high-risk patient, someone who's got a lot of comorbidities, someone who's immunocompromised, I will treat them with 3 days of remdesivir if they're asymptomatic and not hypoxic to decrease their likelihood of progression to more severe COVID, but also because, again, now we have additional data that says if I treat you, you are less likely to have long-term complications neurologically also. Again, the bucket of what's neurologic, I'm sure, is more of a mixed bucket than it appears in the literature, but for those reasons, I would.
Quick question on the patients who have had some sort of venous thromboembolic event, either DVT or stroke. They usually are anticoagulated if we assume that it's related to COVID, and then they have to stop at 3 months down the road or whatever. is there evidence for risk of recurrence if they were to get COVID again? Because some people are very understandably paranoid about what about the next time I get the flu or COVID? Am I going to have another stroke? Am I going to have more clotting problems? Is there evidence?
So I actually did try to look a little bit for something. I could not find very good data to say what that true risk of recurrence is in those populations. And again, I think part of that is actually getting active diagnoses appropriately for patients and following it over time, especially when the majority of the incidences were early in the pandemic where we had some limitations. What we can indirectly say from the literature is that it does appear that once you've had it once, your immune response moves faster and you are less dysregulated over time. And with the drop of incidence, epidemiologically, if I were talking to a patient myself, I'd say I don't know, but if I look at the broader scale, without additional insults, I think the likelihood is lower, but I would never say it's zero. But I think recognition and treatment is really key of early recognition to those patients. A lot of those patients are still very risk averse, are still going to continue mask wearing, a lot of those things to try to mitigate risks. But it's really hard. And if you get hit with something else like influenza, nobody knows. We just haven't had enough influenza and COVID at the same time to have any clue what the long-term implication is, because everybody was masked and we didn't have influenza for 2 years. Australia had the first hit of influenza this year before we did, because they always lead our season, right? And it's still, compared to any other year, was so much less influenza. We really only had one significant peak. We didn't have the normal bimodal peak. So I don't think we're going to know what influenza does to someone who's had COVID until we hit another big influenza season, which everybody's anticipating will rise as all of these other restrictions are coming off. But when that happens is a little unclear. We also had a better influenza vaccine match this year than in other years. If we get a universal influenza vaccine, coming in the next year or two, we may be able to mitigate some of that. But I think influenza is one of the biggest risks with that. Nobody knows, as far as I can tell, what happens if you get COVID and VZV or HSV, where you could have concurrent vascular disease, especially in the CNS happening. There is some data that says COVID will unmask and worsen and propagate HSV, VZV, and there are case reports of it being the trigger to that, but was it really the trigger or not? It's a case report, nobody knows, but we do know that significant viral illness can unmask other latent viruses, right? So causal, not causal, associated with severity of illness, really hard to know the difference of, but there are some where you see duality of worsening disease or getting a second syndrome consistent with the second virus. Whether they're synergistically worse, I don't know.
Thank you very much.
Thank you.
Thank you all for coming. Have a great night. Adjourned.